Hello and welcome to today's webinar. Thank you for your participation. The title of our webinar today is Measure What Matters, Advancing Multidisciplinary Care Coordination in Primary and Subspecialty Care Pediatrics, Part 1. My name is Michelle Esquivel, and it's my honor to serve as one of the moderators for today's webinar. I'm the director of the National Center for Medical Home Implementation and of the Division of Children with Special Needs at the American Academy of Pediatrics. The goal of the National Center for Medical Home Implementation is to ensure that all children and youth, and particularly those with special health care needs, have access to a medical home. As I mentioned, this webinar is the first webinar in a two-part series focused on measuring care coordination. It's brought to you in partnership with our colleagues at the National Center for Care Coordination Technical Assistance, and you'll hear more about that National Center in a few moments. The webinar is supported through a cooperative agreement that we have here between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Service Administration. So we're very grateful to them for their support of the work that we're doing in the area of care coordination and medical home. Before I introduce my co-moderator, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen, and they'll advance automatically. All webinar participants, except for the faculty, are muted, and audio will be streaming through your device, and there's no call-in number. We encourage you to ask questions throughout the presentation by using the question box window on the left-hand side of the screen. So take a moment to familiarize yourself with where that is. These questions will be answered at the end of the presentation. If we don't have time to answer your questions during the actual webinar, we'll send you an answer directly via email at a later time. The webinar is being recorded and it will be archived on the National Center for Medical Home Implementation website. It should be archived within 1 week of today. After the webinar, you'll also receive an email with a link to an evaluation instrument. We really would appreciate all of you taking the time to complete the evaluation. The information that you provide helps us to continue to improve the content and the format for our presentations and educational offerings in the future. Just one very quick note, none of the presenters today have financial or conflict of interest disclosures to announce. And now I'm going to introduce you to my co-moderator and faculty for the webinar today, Dr. Richard Antonelli. Dr. Antonelli is the Medical Director of Integrated Care at Boston Children's Hospital, and he's also on faculty at Harvard Medical School. He's published outcome and cost data of care coordination services for children and youth with special health care needs and their families. He's consulted on care coordination and integration methodologies and measures to multiple states and to U.S. federal agencies. He directs the National Center for Care Coordination Technical Assistance, and as I mentioned, this is also through funding from the U.S. Maternal and Child Health Bureau in partnership with our national center, the National Center for Medical Home Implementation. So Dr. Antonelli, I'm going to turn it over to you now.
Thank you, Michelle, and thanks to the team that made this possible, and in particular, thank you to our federal partners, the U.S. Maternal and Child Health Bureau. None of this would be possible if it weren't for your partnership, support, and guidance, so thank you very, very much. I want to just take a moment to tee up what you're going to hear today, and then be mindful that next week there will be part 2. We're basically going to both celebrate and quantify the diversity of stakeholders for doing care coordination for children and youth with special health care needs. What do I mean by that? If you look at the AAP's policy statement in 2014, care coordination moving us broadly to integration, and I wanted to mention to you the presenters on the faculty for this webinar. You're going to hear from a pediatric subspecialist today. You will hear from Hannah Rosenberg from the National Center with a broad view nationally. And the next week you're going to hear from a primary care provider who has dedicated much effort into care coordination to improve outcomes for patients with behavioral health and developmental and educational needs. And then you're going to hear from a nurse, a frontline RN, who provides lots of care coordination for kids with complex condition, and that condition is linked to the presence of a G-tube. So heterogeneity of the providers by using the same measures of care coordination and outcomes. I also want to call out the fact that we have representation across community-based organization staff today, educational professionals, family members and family advocacy groups, healthcare providers, and state maternal and child health agency staff. In addition to registrants from the United States, there are registrants from at least 2 other countries. And so care coordination is a universal activity. The good news is that it's measurable, it adds value, it improves care outcomes, and we're going to take you into some of the evidence for that today and into next week. And I'm going to hand it over with no further ado to Ms. Hannah Rosenberg, who is the manager of the National Center for Care Coordination Technical Assistance and works with me here at Boston Children's Hospital in the Integrated Care Program.
Great, thanks so much, Rich, and thank you for all of our audience members today for joining us. So I'm going to spend just a few minutes framing for all of you the care coordination measurement tool and providing some background information about the tool, about the process that we've engaged with multiple stakeholders across the country to implement and to be able to capture valuable data. And then I will spend a little bit of time just talking about the first steps that we would recommend taking as you leave this webinar today and are energized to start thinking about how you might use this in your setting. And then we really want to spend the majority of the time today handing it over to Dr. Vaz, who will talk through her experiences implementing the tool, collecting very valuable data, and informing, really being able to inform a new model of care for the children that she serves. So next slide, please. So as we said, we will today introduce the care coordination measurement tool, and we will demonstrate the impact of care coordination in diverse settings. So today you will hear from Dr. Vaz, but next week we encourage you to join us again to hear from 2 different care team members and providers and how they have operationalized the tool as well. Next slide, please. So we come to you from Boston Children's Hospital, but specifically today from the National Center for Care Coordination Technical Assistance. I know that some of our stakeholders and partners are on the call today, but if you haven't yet connected with us, we are a center that partners with National Center for Medical Home Implementation to support the promotion, implementation, and evaluation of care coordination activities and measures in child health. We have a very small team, but the majority of our time we do spend providing one-on-one technical assistance to any entity across the United States who is focused on care coordination measurement, care coordination capacity building, and developing more of an integrated model for children and youth with special health care needs. Next slide, please. We provide, as a center, as I said, introductory level technical assistance with any of the tools that we've developed within our center. That includes the tool that you'll hear about today and some of our other tools and resources focused on capacity building, family experience measure and outcomes, and care coordination. If you're interested in connecting to our team, my contact information is on the slide deck. Please do reach out. The tool that you'll hear today, you'll hear at a very high level, and then you'll hear from groups who have implemented it. But we encourage anyone who's in the initial stages of thinking through use of the tool to reach out to our team and to connect with us. We can share our experiences of implementing it in over 30 settings across the United States, in collecting the data at different clinic-based settings at Boston Children's Hospital, and our experience gathering data and information from groups that have implemented it. So we can bring all of that to the early conversations to help inform how you could best use the tool as well. Next slide, please. Care coordination is a critical component of high quality and safe healthcare delivery, and we define care coordination as any of the activities that occur in the space between those in-person touches. So in-person visits, ED visits, hospitalizations. And as all of you on the call who take care of children and youth with special health care needs as part of your everyday role know, those activities are plentiful, and really they are at the core of providing positive outcomes for children and their families. But those activities are rarely measured and currently not typically reimbursed. However, at our current state, there is an opportunity to inform and to change financing mechanisms and methods as we move away from the traditional fee-for-service model where the child has to be in front of you to be able to bill for that visit, to what we call value-based delivery, where delivery systems are incentivized to provide proactive, comprehensive care to patients and their families, to increase the opportunity for children to have positive outcomes, to reduce high-cost utilization, and to improve the experience for patients and families. So how do we actually measure and collect data that is able to support that claim that these activities support children? So the care coordination measurement tool comes into play there. We call it the CCMT, allows users to collect data that actually connects those activities to occurred and prevented outcomes, and what we mean by that is positive outcomes for children and youth with special health care needs, and demonstrates that it prevents adverse or negative outcomes from occurring. So an example of that is going to the emergency room, having a medication safety error, anything that might happen when they're not actually physically in a healthcare setting. It also allows individuals to collect data around the resources needed to effectively, what we say, operationalize this model. So the time and staff that are necessary to complete these activities in a productive and valuable way. So ultimately what the care coordination measurement tool does is it informs information in the space of quality improvement and financing mechanisms. And I'll hold off a little bit on that. I'll describe that in about 2 more slides. I'll dive into what we mean by QI and financing mechanisms. So next slide, please. So what is the CCMT? It is a tool that demonstrates that when care coordination is successfully implemented, it prevents the use of high-cost resources, as I said, ED utilization, inpatient services, and leads to better experience and outcomes for families. The tool enables users, and when we say users, this is the individual care team member that is documenting the activities and the time and resources that they're using to achieve and these needs for families. It enables users to record the type of encounter. So is this a medical need? Is this a behavioral need? Is this a community service need, an educational need? The complexity level of the patient requiring care coordination, so it allows the users to stratify their patient population. The activities performed, so what was actually done to achieve the need for the family. And then as we've talked about, the outcomes that occur and are prevented. And this is really what we call the value capture space, is that connection between time, resources, activities, and then outcomes for patients and families. And the tool allows users to inform a framework that can help them guide a conversation around how to optimally allocate resources. So as we move into these new financing models, as we try to create more solid approaches to population health management, we really need to gather data that will help us make decisions about how to appropriately and properly allocate resources and time, how to use staff to the best of their ability. Next slide, please. The care coordination measurement tool, we have a template for the tool. And this is really where we generally start out the conversation with folks. And we say that the template is a great place to start, but the real value of the tool comes from that adaptation process in which you take a look at what included in the tool reflects the activities and outcomes in your setting, but you also walk through a process of how you can best think through what activities and outcomes you would like to track and record that reflect the work that you're doing. So I'll quickly speak through the tool, but the real value will come when you hear our other speakers today and next week talk through how they've adapted it. The tool is split up by different domains and response options. We go through patient levels, so stratification, care coordination needs, activities, prevented and occurred outcomes, time spent, staff that is completing the activity, and then clinical competence. So for our clinical team members that are providing care coordination as part of their everyday role, is their clinical license needed to actually conduct these activities? Next slide, please. The tool is, as I said, intended to be adaptable. So we say the template is a great place to start, but the real value comes from your adaptation of it. The first step that we always encourage users to think through is what is the overall goal of collecting this data? So is it to inform a new financing model, to appropriately allocate resources across a team, and to be able to quantitatively justify the resources needed to provide proactive population health management care to this patient population? And or is it to provide quality improvement, which is thinking through across our team, are all of the members doing activities that make sense? And a really good example of that is the clinical competence piece. So our RN staff members, our nursing staff members, doing a lot of non-clinical care coordination activities. And if so, how do we collect that data to make the case that we either need to shift accountability to other team members, or we potentially need to think through hiring a non-clinical person on our team who can take responsibility for those activities. And Dr. Boz will be talking about that later today as well. The tool can be adapted to fit the needs of different settings, and we've talked a little about the clinical space, but we also have partners in the non-medical setting, many Title V statewide program partners, community-based services that serve complex care populations. We have family professional partnership and advocacy groups, academic medical centers, and small community-based practices, all that use the tool. So it's really intended to span this diverse group of stakeholders. The tool can be implemented in different ways, and as I said, we always recommend that you reach out to our group to start thinking through this process. But we recommend different methods for thinking through collecting the data, either one day a week or 1 week every quarter, so it's not intended to be a every single encounter type of tool. Or more frequent data if you're developing a business case to be able to re-engineer financing. We have here at the hospital, we've developed an electronic version of the tool that is embedded into our electronic medical record system. Next week, you'll hear from a member of here at Boston Children's Hospital who used the tool in that way. But you could also use it in paper form as well. There's currently not a recommended amount of care coordination measurement tools that are required to accrue what we call sufficient data to start looking at and making changes based on the data that you're getting back in the space of QI. When developing a business case, that's a little different, and we can talk through that as well. And there is a process for that validation that we can help you think through and actually conduct in your group. Although when used in QI, generally the tool does not require validation. Next slide, please. We also have an adaptation and implementation guide that we've put together that is based on our experiences working with multiple stakeholders to implement this tool. It's a great resource. It can be found on our website, Boston Children's Hospital. It can be found on the National Center for Medical Home Implementation's website. But in addition to looking at the guide, we always do recommend that in addition to that, you reach out to our group, because we can provide that one-on-one technical assistance to your group early on. We recommend broadly that you include all care team members who support care coordination activities. So when you're implementing this tool, it can be implemented across the team, and Dr. Voss will talk about her experience doing that as well. That you ensure all activities in your setting are reflected, so that was the adaptation piece. You make sure that you do due diligence early on to ensure you're collecting valid and valuable data. You create specific definitions around the response options in your tool. We have a process for that, and it's included in our guide as well. And that you always use an iterative approach to launching the tool. So we always recommend that you pilot test the tool early on, make changes based on user experience before it's formally launched. And we, again, can guide you with that process. The next slide, please. We have many resources related to care coordination, capacity building, and measurement in addition to the CCMT. These are some links that you can find some additional information that we've put together and that are available to you. Next slide, please. But please do reach out to us. You can contact me directly by email or phone, and I can connect you to our team, or you could connect to the National Center for Medical Home Implementation. And again, all of the speakers that you'll hear from, our team has been connected to them and has been working with them as well. So we're happy to help. Next slide, please. So I'm now honored to introduce Louise Voss. Dr. Voss is a pediatric infectious disease specialist at Dornbecker Children's Hospital and Oregon Health and Sciences University. And Dr. Voss will share how she was able to use the care coordination measurement tool to assess the demand for and outcomes of her outpatient antibiotics program as a component of a broader delivery system. So Dr. Voss, I'm pleased to turn it over to you.
Great. Hello, everyone, and thank you so much for having me today. Next slide. I'm looking forward to sharing with you our experience with using the CCMT in our infectious disease program. And so I'll present today about utilizing a modified care coordination tool to provide evidence for value in our particular pediatric parenteral antibiotic therapy program. Next slide, please. I'm an infectious disease doctor, and many of you may be wondering, what does an ID doctor have to do with care coordination in medical homes? And so I wanted to share with you a special program that we have and how we found a way to use care coordination and the care coordination tool for the work that we do. So what is OPAT? I'll keep using that term. It stands for outpatient parenteral or prolonged antibiotic therapy. It enables patients with serious infections in the hospital to be able to go home to complete their therapy with either IV antibiotics or medicines by mouth in their home setting. And given it allows us to care for really complex patients, such as those with heart, brain, hardware, and other serious infections. And given the complexity of this and the delivery of potentially toxic medications via central lines in a home setting, there have been specific guidelines that have been created by our Society of Infectious Diseases regarding how best these patients should be followed. And it was under these auspices that the framework to take care of these patients that our program was born. And while the term care coordination wasn't necessarily in vogue back in 2004 when these guidelines were created, folks in infectious diseases have been doing and practicing care coordination precisely this for a very long time. Next slide, please. So a little bit about OPAT. Prior studies have shown improved outcomes and that OPAT is safe, it's effective, we can send these kids home to complete their therapy, and this increases their quality of life and reduces hospital costs. And as Hannah mentioned, given the changing field of healthcare toward more value-based care, finding ways to reduce lengths of stay and unnecessary healthcare utilization are key drivers for hospital and payer systems. And OPAT nicely is a key example of how this can be done. And while we all recognize the importance and challenges of being able to care for kids in the home setting, the reality is, at least for infectious diseases, is that Ambulatory infectious disease services often serve as liaisons or consults for community providers. So we're doing a lot of triage with our community providers. Ambulatory care for infectious diseases is often limited, both in terms of number of humans and finances involved. And we do an extensive amount of care coordination, and I'll demonstrate some of what we do. As Hannah mentioned, all this care coordination is non-reimbursed, and essentially we have it's an unfunded mandate. We all recognize that taking care of these kids is the right thing to do, but not all the work that we do is reflective in how we bill or what people see in terms of administration, in terms of our productivity. Again, infectious diseases is largely inpatient focused, and not all places have a separate and formal OPAT program, but we're all doing this work and trying to recognize that is important as well. And so we recognize globally that being able to care for kids in the home setting, and many of you guys that are listening in also can relate to this as well. And next slide. What we wanted to demonstrate as well is what would happen if we weren't here. And what we were able to do is able to at least make note retrospectively by looking at prior charts what happened when OPAT didn't exist. And what we saw was, and at least anecdotally noted, there was a lack of systematic discharge processes, readmissions and ER visits were increased. We had a lot of near and missed events. We had kids that were lost to follow-up where we didn't know what happened to them. We saw kids going out with medication areas, the wrong drug or a wrong dose. We had evidence of central lines that we didn't have documentation whether they were actually removed at the end of therapy or not. And then also some concerns just in terms of adverse events. Sometimes when you put kids on prolonged antibiotics, you can have what we call neutropenia, low white blood cell counts, some liver problems, et cetera. So we also had nuances of either maybe too long or too short of antibiotics. So what we began to make a note was that there are a lot of ways that we could do things better. Next slide, please. Luckily for us, an adult version of OPAT was really well established in our hospital in terms of our main hospital, and thus when we were leveraging the pediatric case, we had the advantage of riding on the coattails of our wonderful adult colleagues, such that leadership was already familiar with the concept of OPAT and some of the adult outcomes. And thus our real objective was really to demonstrate to our hospital administration that pediatrics is important too and justifies investment. And this is not always obvious based on our RVUs or the number of clinic visits. Our hospital was gracious enough to fund a pediatric program. And with this, we have fewer numbers in pediatrics, and of course this was a new program. So we needed to justify the expense and the investment that the hospital was putting in for us. So we sought to try and find a measurement tool to do this, and back in 2015, luckily, the care coordination measurement tool was available, and we utilized this. We were able to utilize something that was already published and had experience in order to identify our non-billable efforts, and enabled us to organize and examine our outcomes to actually maximize our potential interventions. And basically, it allowed us to augment our ad hoc experience by providing actual data on the work that we did. Next slide, please. I wanted to share with you a little bit about our hospital and our program for some context as we review some of the results. Our facility is a 148-bed facility. It's the only academic children's hospital in Oregon and serves a surrounding catchment area as well. Our program is separate from the adults, although we are children's hospital embedded in a larger adult hospital. And our hospital funded this program beginning in January 1st of 2015. It's staffed by a pediatric ID doctor with full-time, with partial support for OPAT, and also an advanced practice provider as well. What it didn't have when we started was no pharmacist, no medical assistant, no RN. And in addition, we also wanted to capture the kids that were going out on IV antibiotics, but the ones that were also on oral antibiotics as well, in terms of trying to extend the benefit of our program to more children. Next slide, please. Additionally, there are some specialties that continue to follow their own patients, and thus we were a non-mandated program. Services could opt out, and such programs that already had wonderful wraparound services, such as cystic fibrosis and the hematology oncology service, continue to take care of their own patients. But our program really captured the patients that didn't have otherwise medical homes to take care of them. Our program had 3 components. As you see here, there's an inpatient assessment where there's a warm handoff between the inpatient and our teams. There's a meet and greet with the family where we say hello and get to know them. And there's also a teach session where we talk about the infection and how we're going to treat this, both with the family and with ourselves in the outpatient setting. There's the care transition process from the inpatient to outpatient setting, and as many of you know, this is the time of greatest risk, and so there's a lot of hand-holding and follow-up in this time period. And then there's the outpatient management, the lab, the lines, the outpatient care with the families, the subspecialists, the primary care providers, home health companies, laboratories, infusion pharmacies, and schools and other agencies and daycares, for example, that also help take care of these kids. Next slide, please. So these were our methods. So back in 2015, we had an idea to do a qualitative feasibility pilot. We took all our kids that were enrolled in our program, and we adapted the CCMT for OPAT. Our program at that time was very small. It was just myself, an advanced practice provider, and we did this daily during the work week for a 2-month period, and this allotted to about 44 actual days. We entered the data in a REDCap database, and we used summary statistics and qualitative data were generated from this, and our IRB granted a waiver for this QI project. Next slide, please. So this is our adaptation. We spent a significant time before we actually implemented the CCMT to actually align the CCMT with our workflow, our care coordination needs, and what our outcomes were. And the result is this form that we used. We implemented it as a piece of paper filled out daily in real time, and we discussed and tried other modalities such as using Excel or other database things, but in the end, with our busy day, we ended up just doing a paper version of this, and then the data was entered into REDCap. Next slide, please. I'm going to share with you now some of our results and what we got out of this tool, which I think is actually the fun part. So over this 2-month period, we had 154 separate care coordination events for 29 different patients. These patients were aged 17 months to 15 years, and they're spread all over Oregon, from the urban areas to more rural areas that are nearly 5 hours away, and a majority of our patients were publicly insured. Most of the time we spent doing our care coordination was over a phone. 62% of our care coordination was done this way. And we spent a lot of time talking with families and also with other entities such as pharmacies and home care companies. I thought what was surprising was that we didn't spend as much time as I thought that we were doing in terms of using electronic medical record to communicate with our various other stakeholders, and less so also with email and in-person stuff. So I would imagine this is likely to change over time as with new interfaces and new technologies we go forward. So our tool allowed us to measure all these non-billable and key components and value of the work. What we took away from our work was that there was a lot of work that we were doing, and some of this work actually prevented ER visits. So we had 10 ER visits that were prevented that we were able to quantify. We also had 2 hospitalization events that we also prevented. We spent a lot of time in care coordination and a lot of time and also resources. And what much of our care coordination could have probably been outsourced in terms of us spending time obtaining labs and faxing prescriptions and doing these phone check-ins. And some of the results and details of our findings were published before, and we'll have the citation later as well if you need more information. Next slide, please. As a result of the CCMT, it's really, I think, powerful about what the CCMT did for us going forward. And I think we were able to leverage some of the work that we did with the CCMT to actually gain a medical assistant in 2016. In 2017, we were able to allocate some time to a registered nurse for a phone triage, so our team is growing. And given the importance that we found in terms of the social complexity of our patients, we have started to do a social risk screening to identify some of these high-risk patients before they're discharged, so we can do some planning with them and to try and better help them in the post-discharge period. And this includes identifying family challenges in a more formal study that we're doing now. What is nice also about the CCMT, it's become part of our daily life, and that we've been able to embed parts of it within our EMR, where we're actually thinking about and trying and track these preventable events. We're also tracking our numbers of our encounters and the time that we spent within our EMR. This is not without challenges, as you can see here in this graph. We were projected to start out with about 75 patients in our program, and we've outpaced that, and trying to figure out now about how do we leverage the resources that we have to effectively keep taking care of all of these patients. And so we're constantly thinking about that as well. Next slide, please. So in terms of lessons learned, what we found was that using the CCMT and identifying every step in our process, it really helped us understand where we were devoting our time and our resources and where we could do better. We know that care coordination is essential, and this really made it evident. All the communication needs to be clear, needs to be concise, it needs to be well documented, and there are a lot of people that it all needs to get communicated to in a timely fashion, and we do that on a daily basis. And what we found was that an appropriate division of labor really led to a better functioning team, and I think overall provided better care for our patients. Next slide, please. And so I would love to suggest that other specialists and other specialty type of groups try this in their practice and programs. There's a huge need in subspecialty services in terms of the data needed to support the work that we do. Certain particular niche areas with certain patients with high complexity could also benefit from this. And we can avoid redundancy and build better relationships with a patient's medical home if we understand what we do to reduce duplicative efforts down the line. Next slide. So with that, I just wanted to leave you with my contact information, and I'm happy to serve as a resource for anyone with further questions arise. Next slide.
Thank you so much, Dr. Voss, for an extremely practical and informative presentation. It was excellent. We really appreciate it. And to Hannah as well for her overview at the outset of the webinar. We do have time for questions from the participants on the webinar today. We have almost 300 people participating, so we'll try to manage the questions in a logical and thematic way. And again, as I mentioned at the outset, we will get back to you after the webinar with answers to questions if we don't get to them during the time of the webinar available. As a reminder, please submit your questions through the chat box. And Alex Kuznetsov, my colleague here at the National Center for Medical Home Implementation in the American Academy of Pediatrics, is going to facilitate and moderate the question and answer session. So Alex, I'll turn it over to you.
Thank you, Michelle. So we do have a couple of questions, and this first question is both for Hannah Rosenberg and Louise Voss. And so the question is about EMRs, electronic medical records. And can you talk a little bit more about integration of the care coordination measurement tool into EMR systems, if you've had that experience?
Yeah, so this is Hannah. I can speak first and then turn it over to Dr. Voss. So what we've done here at Boston Children's Hospital is we've been able to embed a link into the banner bar of our electronic medical record. So in order to make it as easily incorporated into workflow as possible, CCMT users are able to be in a chart, click on the link, which auto-populates some information, and then complete the tool and submit it. To note, none of the data actually flows into the chart. It's all in a separate database that our team manages. We do have experience, though, with other groups, and I believe that Dr. Vaz can speak to this as well, with other groups who have actually embedded some of the measures into their EMR, so the data is collected within the EMR. So Dr. Vaz, do you want to talk about your experience for a moment?
Yes, I'll be happy to. Within our EMR, we use Epic. We were able to create a smart form that's specific to our program. And within the smart form, we have discrete fields that note the number of encounters and in terms of make at least a place to be able to put the preventative events, but also things that did happen when they actually did go to an ER or a hospitalization event. This feeds into a monthly summary output for us that we're able to sit there and look and quantify on a monthly basis about the care coordination that we're doing. So while it's not the exact same tool, we took elements of the things that we want to track going forward into a smart form within Epic. On the other side, too, is just in terms of our templates and how we communicate our information, but in terms of capturing the care coordination, we write short notes when we do coordination with our families so that we know what we're doing and we're documenting, at least internally, some of the time that we're spending with these families doing this.
Great, thank you. Our second question is also for Dr. Vaz and probably Hannah as well. And so the question relates to the time burden required for staff to complete the tool. Can you talk a little bit about whether or not there was more time required or less time required and how that has impacted your staffing and your capacity?
Hannah, I'm sorry, the part of that cut out. Could you repeat that question?
Yes, my apologies. So the question had to do with staffing, whether or not your staff reported a time burden related to completing the tool. So you could talk a little bit more about that and about staff capacity.
Yeah, and I think one being the one of the people that actually had to do it herself, and our advanced practice provider as well. I think in the beginning it was hard. One, because I think even though we had developed this tool ourselves, we had to figure out on this piece of paper where things were in terms of which activity visually where it was and how to find it. So in terms of, again, we went through various iterations to try and simplify it as well. But I think as time went on, it got a little bit easier because we realized that we were kind of doing some of the same activities over and over again. And so we were able to quantify a phone call and a fax that was placed in an order placed, and we kind of remembered all of those numbers and what in terms of documenting that. So yes, so there was some time and probably a little bit of, honestly, there was some frustration I think in the beginning, but it got much easier as we went along, and I think that we were able to end up with a better tool after these various iterations that we did.
And this is Hannah. I can just iterate that generally, I think that reflects general experiences. So we encourage groups to think through the tool in a way that ultimately, once the team is onboarded and familiar, it takes no less than 60 seconds to complete the tool. So it should not be a time-intensive activity. If it is, then we encourage groups to rethink how the tool is constructed and how the process is occurring. But I think that Dr. Vaz really explained well. Generally, there is a learning curve for just understanding the tool and how to use it and familiarizing the team with the different response options in the tool does take a little bit of ramp-up time.
Great. So I know we're getting to the end of our time, but we will take one more question. So this question is for both of you, and the question has to do with what disciplines besides nursing are involved in care coordination activities? So for example, can social workers perform some of the care coordination activities, and can you speak more to that?
Yeah, this is Hannah. I can speak first. So absolutely, we've seen the tool be used by completely non-clinical staff, so social work, care coordinators who are sometimes RN level, but sometimes are not, are non-clinical care coordinators. We've had family and patient navigators use the tool. We sometimes do have physicians and nurse practitioners who will use the tool, but capture their non-billable activities. We've had dietitians on complex care teams use the tool. So it really is representative of any team member across a multidisciplinary team that is contributing to the health and outcomes for children in between in-person visits, which, as we know, oftentimes is multiple people. So absolutely it can and has been used for non-RN staff members as well. And Dr. Buzz, wanted to speak to who on your team was collecting data?
So on our team, it was myself and the advanced practice practitioner, and that's all the team that we had, and so that's who was doing all the data collection. But I would echo Hannah as well in terms of that schedulers, MAs, anyone really can do this tool, and I think it really does show with the flexibility of what this tool can do in terms of who can use it and how you can modify it.
Thank you so much. This is Michelle Esquivel again. We appreciate the questions, and there are lots more that we will respond to after the webinar. And we thank our faculty, Hannah and Dr. Vaz, again for their experiential presentations and for their expertise. We appreciate all of your time. Those of you who are participating on the webinar, we hope that you've learned something and that you've enjoyed the practicality of the content that was provided. And as mentioned, the recording, the slides, and any unanswered questions will be available within a week from today on the National Center for Medical Home Implementation website, which is www.medicalhomeinfo.org. And then as a reminder, the second part of this webinar series will take place next Thursday, so that's May 17th, from noon until 12:45 Eastern Time. So again, Thursday, May 17th, from noon until 12:45 Eastern Time. And the second half of the webinar series will feature 2 additional guest faculty who are actually utilizing the CCMT tool in practice. Thank you again for your participation, and we hope as many of you as possible will complete the evaluation that's sent to you after the webinar. Have a wonderful afternoon.